I think so. Yeah.
Everybody, we just merged the two sessions, session 7 and session 8, dealing with lymphoma. So it's a great pleasure now to introduce the first speaker, who will be Fowler. We'll be talking about the state of the heart in MD Anderson, about the treatment of lymphomas. Please.
All right, thank you guys. I know you're getting a lot of information. I just flew in from Moscow about 2 hours ago, and the good news is, in Russia, this meeting is running on time. So we're 1 hour, but we are going to catch up, I think, right? And so we'll all be good. So this is I was asked to speak about the art of lymphoma, and which is a very broad topic. So I kind of to focus on indolent lymphomas, which is mainly what I see and do research on in Houston. And I'd like to start with this graph because really, if you think about indolent lymphomas and how we've treated them over the last, 40 or so years, although the frontline treatments have not dramatically changed, the survival has been improving with each era of therapy. And this is data back from 1940s until the 2000s at MD Anderson. And you can see that you'd much rather be on this red line than on the blue line here, where your median overall survival, or I should say your survival at 120 months, 72% versus 17%. So there's several ways to think about this curve, but I think one of the most, well, I guess the two most important things are that most of your patients who are diagnosed with low-grade lymphoma are not going to die of their disease. And so that brings up the second point, is that you don't want to give them a potentially serious or life-threatening toxicity if their lymphoma is not going to kill them. So this is really evolving, and I think when we're thinking about how we treat these patients, especially in the front line, we have to be careful about over-treating them because a lot of these patients' survival is going to be the same as someone without lymphoma. This is how we've treated people in Houston over the past, I don't know, say 30, 35 years. If you were on a clinical trial at MD Anderson and you came here, came there in the 1970s, we would give you CHOP with bleomycin. We then added interferon, one of the first immunotherapies before immunotherapy was sexy. We then added alternating triple therapy. Alternating triple therapy is a very intense chemotherapy where patients had 12 cycles of basically combination chemotherapy with CHOP-based therapy, high-dose methotrexate, ESHAP, and then we gave them a year of interferon maintenance. And finally, before we moved on to things like lenalidomide, where we're using fludarabine with navantone and decadron with rituximab and with interferon. And I want to point out here, I guess I can't move, is that if you look at these survival curves, they look pretty good. Each era we're learning. We're getting better, and people are living longer. But if you look at the failure-free survival, I think it's much less impressive. And most people who had even alternating triple therapy, basically transplant-like chemotherapy, most of these patients are still progressing within the first 5 years. And frankly, it wasn't all that much better than rituximab, fludarabine, or CHOP bleomycin. Again, if you look at the 5-year progression-free survival, most of these patients are still progressing within the first 5 years. But the good news is that if you look at the plateau here, several patients are achieving long-term remissions, and it happens around 8 years. And I usually tell my patients in clinic, when we hit around 8 years, look at the change in the slope of the curve here. If you get beyond 8 years, your odds of relapsing at 15, 20 years is only another 5 to 10%. So most of the risk of relapse occurs in the first 5 years. And I think, although we tell patients this is incurable cancer, I don't think that's true. There are a population of patients, well, I should say either will be cured or will never relapse of their disease. And again, this brings up this question. In these populations, what is the right therapy? Right? These patients are potentially cured, and we don't want to over-treat them. Now, the good news is that regardless of how you treat patients in the front line, most things work. If you use rituximab with bendamustine, with CHOP, with lenalidomide, with CVP, your overall response rate's around 70 to 80% no matter what you do. Progression-free survival, the average progression-free survival with most of these rituximab-containing regimens is somewhere around 5 to 10 years. So pretty good. This is the 2-year, but the median is going to around 5 to 10 years. Now, as I mentioned, although that's good, most of these patients, regardless of the backbone, still relapse within the first 5 years. So there were a lot of efforts about 10, 15 years ago to try to extend progression-free survival. And those efforts mainly centered around using consolidation approaches with radioimmunotherapy or maintenance therapy. We did a lot of studies at MD Anderson where we used maintenance interferon, didn't do a lot. This is the PRIMA trial, and I think most of you that treat lymphoma know this trial. Pretty simple design. Everyone got backbone of CHOP chemotherapy, and they were randomized to receive maintenance rituximab or not. And this right here was just presented about a year and a half ago, is the 10-year follow-up of patients who received maintenance. And you can see that patients who receive maintenance maintenance rituximab after chemotherapy, half of them at 10 years are still in remission. But in English, we have a saying that you can look at the glass half full or half empty. In the patients who did not have treatment, the remission is still, the patients who did not have maintenance, the remission is still 35%. And if you look at the overall survival, it's identical between the two curves, even at 10 years follow-up. So I think, again, with regards to maintenance, whether you use it or not, it probably is not going to make your patient live any longer. It does translate to a slightly higher advantage in progression-free survival at 10 years, although that's counterbalanced with higher rates of infection. And I know that, here's your overall survival, really pretty much identical. Now, what does cure patients? We've known that allogeneic transplant is curative in the majority of patients with relapsed follicular lymphomas. So you may ask, okay, then why are we not doing this in all of our patients? The problem is this curve in the first 18 months. Around 15% of patients die following the transplant, either due to rapid progression or to toxicity or graft versus host disease. So we have a curative regimen. The problem is we can't predict, unfortunately, who is going to die of the disease, and this is pretty much fairly consistent around 10 to 15%. So what I tried to show you in those first couple slides is that most patients will relapse with standard chemotherapy. Allogeneic transplant is curative, but is significantly toxic. We know from allotransplant, we know from things like interferon and rituximab that this is a disease that's sensitive to the microenvironment and changes in the host immunity. And so, a lot of the current work is looking at integrating immunomodulatory drugs. Lenalidomide is probably the best known of these drugs, and you probably never think that I would say this, but lenalidomide is not a good drug for follicular lymphoma as a single agent. If you look at the median progression-free survival, only 4 months if you use this drug by itself in relapsed follicular lymphomas with an overall response rate of 27%. But we know now from a lot of data coming out of myeloma, or came out of myeloma and in CLL, that the drug is a very potent immunomodulatory drug. And so what happens when this drug is given, there's a change in the activity level and the function and the secretion of certain cytokines by NK cells and T cells. And this results in increased ADCC, or increased antibody-dependent cellular cytotoxicity. And if you believe this is the primary mechanism of rituximab, it's not too much of a stretch that maybe you could use a drug like this with a monoclonal antibody. This is a phase 2 trial it's an old trial now, using lenalidomide with rituximab. And when we did that, you can see the overall response rates were pretty good, almost 100%, 98% with frontline follicular lymphoma with a complete remission rate of 87%. It also works in marginal zone lymphoma and in SLL, although not quite as high CR rates. These are the progression-free survival curves of this phase 2 trial. And you can see the PFS at around 5 years is around almost 70%. The other thing I think is interesting to point out here is that look at your overall survival, and we now have 7.5-year median follow-up. You don't see this 20% that we've seen in several other publications that tend to die within the first 5 years. So our overall survival was very good. Now, these patients did not all have Guelph criteria, but at least in the subset of patients that we enrolled, there didn't appear to be this 1 out of 5 that has poor survival in the first 5 years. Now, one of the purposes of this trial was also to look at the effects on the immune microenvironment, and so we did gene expression profiling patients both pre and during treatment, and we found that gene expression selected patients that were more likely to respond if they had an activated T cell it's a genotypic signature. And this was very interesting. We did these same studies, gene expression, looking at this activated T cell signature in patients who received CHOP or bendamustine, and saw it was not predictive in patients that received chemotherapy backbones. Again, suggesting that patients that start treatment with an activated T cell phenotype were more likely to respond to immunotherapy, which is not a big shock, right? Now, in that trial, we did a couple different versions. We did the very first study, which has been published. We only did 6 months of treatment in follicular lymphoma, and we did a second cohort of 30 patients, which we have yet to publish. This is some of that data, which we'll be presenting at this ASH, hopefully. And we saw that if you look at the overall survival here, there was no difference whether patients got 6 or 12 cycles. There was a slight trend towards improved progression-free survival, although it was minimal in patients that received 12 cycles compared to 6 cycles. And I'll get back to that in the last couple minutes. Now, this is a phase 2 trial, so the only way to really show if this works is do a phase 3 trial, and this was the relevance trial. Pretty simple design, 1-to-1 randomization. Relevance stood for Revlimid versus any chemotherapy. And this was a study that occurred here in Italy, along with several centers in Europe. Pretty simple design, lenalidomide rituximab or rituximab plus chemotherapy. Both arms had maintenance. Overall response rates were very similar between the two groups, slightly higher CR rate with rituximab plus chemo, but if you look at the duration of the response, it was actually slightly higher with lenalidomide. Progression-free survival, both by the investigator and by independent review, was pretty much identical, 77% versus 78% with our chemo. And so this was really the first time, I think, that we were able to show in a prospective fashion that you could use a non-chemo regimen and have the same impact, same outcome as patients who receive chemotherapy. Now, one of the other goals of this trial was to look at the toxicity profile between the two groups. We saw higher rates of neutropenia, higher rates of febrile neutropenia, higher rates of hospitalizations due to infections in patients who received chemotherapy with rituximab compared to R squared. There was higher rates of rash with lenalidomide, but only 2% of patients had to stop trial due to rash. And this higher rate of neutropenia here in the chemo arm was despite the fact that the chemo patients received 3 times more growth factor than lenalidomide, and they still had almost twice the rate of neutropenia. So I think it's a less toxic regimen that gets you to the same endpoint. So, but we're not stopping, and we are trying to look at other versions of this R squared. We have 2 large trials which will be presented at ASH this year using lenalidomide and obinutuzumab, both in the frontline setting and in the relapse setting. It's a pretty similar design as the R squared. We enrolled 60 patients in the relapse study and 90 patients in the frontline trial. And again, this data will be presented at ASH. This is some preliminary results, very high remission rates, 100% overall response rate in the relapse setting. But again, this was only in the first, I think, 14 or 15 patients. So I encourage you to come by and see us if we get selected for a presentation. So this is my conclusion slide, and I promised you I will stay on time, so I have 1 minute left. In my opinion, what's the state-of-the-art therapy for low-grade lymphomas? In patients who you suspect transformation, they should get CHOP chemotherapy. This is absolutely essential. And we've seen this now in several studies that patients who relapse early, it's usually because they have occult transformation. So if you suspect transformation, even if the biopsy is negative, meaning the biopsy shows a grade 2 follicular. If you have a PET scan with a high SUV, the patient presents with a high LDH or rapidly progressing disease, even if the pathology says low-grade lymphoma, I treat them with CHOP as if they have transformation. If they are not transforming clinically or by pathology, then I would do bendamustine rituximab or R squared, and especially obviously avoid CHOP if they have a history of heart disease or prior exposure, for example, breast cancer patients who have received prior adriamycin. We have several studies ongoing. I just showed you a very small heat map, but we have a very large effort ongoing to do genomic profiling in patients with R squared to hopefully predict which of your patients should get R squared, which should get rituximab plus bendamustine. But until we have that data, I think it's not a very satisfactory answer, but I think all options are okay because they all work pretty well. And I would really just talk to the patient about the side effect profile, the length of treatment, and you won't go wrong. So thank you for your attention. Yes.
For this comprehensive and exhaustive overview on indolent lymphoma, which is now open for discussion.
Yes.
Is there any question or comments or remarks from the audience?
Nathan, may I ask you one further comment on rituximab maintenance?
Yes.
Do you think that in this era of novel agents, combinations, a lot of new clinical trials, is still worth to candidate a patient to rituximab maintenance?
So if I understand the question, in the newer trials or the newer version, how can you extrapolate maintenance, the effect of maintenance? Is that?
No. The question was if a patient receives R-Benda or R-CHOP outside a clinical trial and then is candidate to rituximab maintenance.
Yeah.
Since there are several trials, do you still think that maintenance is a good option or?
Yeah, so I personally am not a big user of maintenance therapy in patients who achieve complete remission. So that's really, for me, the main determinant of whether or not to do maintenance. If they achieve complete remission with lenalidomide, bendamustine, CHOP, I do not do maintenance. With maybe one exception. Occasionally I see patients that present with very bulky disease, and although PET scan is negative, I suspect that they're still at high risk of relapse because there are some nodes that are slightly enlarged. I don't have any evidence that maintenance is better for this population, but if I suspect they're at high risk for early relapse, I sometimes will also add maintenance. But the general patient, 50 years old, 60 years old, complete remission, no maintenance, regardless of the induction.
Any further question? If not, thank you again.
Thank you.
For your presentation.
Yes. And we are on time because we had a couple cancellations. And so we're going to talk about New Frontiers in Aggressive Non-Hodgkin's Lymphoma by Dr. Carlos Stella.
First of all, let me thank Giovanni Martinelli and Claudio Cerchione for inviting me. I was expected to present a few slides on CAR T cells, but then a couple of days ago I was asked to make a focus on these new frontiers in non-Hodgkin lymphoma, and so I put together some slides and I will try to quickly review these data. Aggressive lymphoma. The question is, this is a very heterogeneous clinical setting with different histopathological categories, with a great degree of molecular heterogeneity and also clinical presentation. I don't want to go to this complex list, but just to make the point is why do we need new treatments or trials, or why there is a search for more effective treatment. The answer is in this slide, showing that the LBCL patients receiving R-CHOP in the first 2 years after ending first-line chemotherapy experience a 30% relapse progression, and then late there is a plateau of the time to progression curve, showing or suggesting late cure. The overall survival curve is essentially overlapping the time to progression, suggesting a low effectiveness of salvage therapy. This means that there are at least 10 to 15% of the LBCL patients that are primary refractory, and 25 to 35 they relapse after achieving complete remission. This is the reasons for this great interest in this setting. Essentially, 40, sometimes 50% of the LBCL patients are not cured by conventional R-CHOP. Immunotherapy has provided a great support in this field. I will not be able to go through all these different aspects, and I have only 3 slides on the role of checkpoint blockade therapy in the LBCL, and then I will mention antibody drug conjugated and bispecific antibodies. Just to give you a taste of what we can obtain in relapsed or refractory DLBCL and what we can expect in the near future by combining these novel agents with chemotherapy. PD-1, PD-L1 expression. The DLBCL essentially do not express, the DLBCL cells do not express PD-L1, but there are some subsets which are highly expressing PD-L1, and these include the EBV virus positive, DLBCL, but also include some 15% of the LBCL who are expressing by genetic translocation, which is the same to that we know in Hodgkin lymphoma. With the same mechanism, they overexpress PD-L1. So there is a large and heterogeneous category of what has been called PD-L1 expressing lymphomas, which includes primary mediastinal B-cell lymphoma, grade zone lymphoma, primary CNS lymphoma, primary testicular lymphoma, Richter transformation of CLL, and a variety of EBV and virus-related lymphomas that have an intense expression of PD-L1. So these patients, despite the general concept that checkpoint inhibitors are not effective in the LBCL, these specific subcategories may experience excellent response, and this has been the case for a study recently published in JCO. In that study, this was a phase 1-2 study using the combination nivolumab plus brentuximab vedotin in patients expressing even a low percentage of CD30 positive cells, and these patients had an excellent response rate with a very high percentage of complete remissions, and these patients could be finally, or several of these patients were finally consolidated with allografting. So the statement that checkpoint inhibitors are not useful in the LBCL is not true, at least completely true. It's a matter of identifying a specific subset of patients. Now, let's move to the antibody drug conjugated. Just one example. This is the very difficult name, loncastuximab tesirine. This is an anti-CD19, antibody conjugated with a pyrrolobenzodiazepine derived. That is a PBD dimer, which is cytotoxic, highly cytotoxic at nanomolar concentration. The mechanism of action is similar to that of rituximab, and you know them. The only difference is the target antigen CD19 and the conjugation with this PBD dimer. The anti-CD19 binds the is a receptor, the antibody is internalized, the PBD dimer is released intracellularly and moves to the nucleus and binds to DNA. DNA is, the replication is blocked of DNA and the cells die by apoptosis. This is an interesting type of antibody which has been tested in phase 1 and now in phase 2 studies. We have recently concluded also the phase 2, and we are running now a phase 2 of combination of anti-CD19 plus ibrutinib in non-germinal center DLBCL. I have a few slides on the results of the phase 1, which included dose part 1, which was a dose finding, and then part 2 was a dose expansion. In the dose expansion, 129 DLBCL were treated. 26% of these, 20% of these patients were refractory to first line, and 60% were refractory to last line of chemotherapy. They had received more than 3 lines of previous therapy, 38%, less than 3, 62. Overall, they were highly, what we can consider highly pretreated patients. Toxicity, it's not irrelevant, especially in terms of liver toxicity. There is 20% of the patients do express this increased gamma glutamyl transferase, gamma GT, in terms of more than grade 3 adverse event. They also experience hematological abnormalities as shown by a 38% of neutropenia and 27% thrombocytopenia. Usually these adverse events are not long-lasting. They are reversible by delaying additional therapy. What about the response? As you see in this waterfall plot, more than 50% of the patients do experience some degree of tumor shrinking, of nodal reduction, with about 40 to 45% experiencing either complete or partial remission. By looking at subgroups, there are some interesting data emerging. For example, patients who respond better are those without bulky disease, 47% of response. Those who are not double or triple hit, 48% of response versus 23%. And those who are relapsed, 53 versus refractory 23. This is not expected, but this is a way just to have an idea of how to select patients for future studies. Duration of response, this is not impressive, in that 4 months of duration of response on average, independent of irrespective of the age of these patients, but the response were deep responses as evaluated by PET CT scan. And we use it on several of these patients experiencing complete response or very good partial response. We use this treatment to then consolidate the response with an allogeneic transplant in these highly pretreated refractory patients, and we were successful in doing this. So again, this is a suggestion as to this drug can be used in the future, even as a monotherapy. Okay, this is a bispecific antibody. This is another interesting class of novel agents. This is a CD20, CD3 antibody with a 2-to-1 ratio as the ratio between CD20 and CD3. The single molecule has 2 binding sites for CD20 and 1 for CD3. The injection in vivo of this antibody is associated with a very quick activation of T cells after the binding with the antibody. Again, this was a phase 1 study comprising a part 1 of dose finding. The dose finding started at 5 microgram per kilogram up to 25 milligram. And then was followed by a part 2 of expansion. The expansion was performed at 16 milligrams. Patients, again, very highly pre-treated and refractory patients. In this case, 87% of patients were refractory to any prior therapy, with 72% of the patients refractory to the most recent line of therapy. The majority of the patients enrolled at this phase 1 were the LBCL, but there was also a nice group of transformed follicular lymphomas and as well as primary mediastinal B-cell lymphoma. What about toxicity? Cytokine release syndrome was a major concern when we started the trial, but actually, as a matter of fact, only 9% of the patients experienced a grade 3 or above cytokine release syndrome, which in a couple of patients required tocilizumab administration, but essentially it was not associated with any grade 5 toxicity. Neurotoxicity, in contrast, was very limited, if any, and we had only 2%, one case of neurotoxicity more than grade 3. So the toxicity is present, but it can be managed with a careful clinical management of these patients. What about the anti-tumor activity? Just remember that these were highly pre-treated, and 80% of them were primary refractory patients, refractory to the first line of therapy. And again, we have about 70 or more % of the patients experiencing some kind of nodal reduction with a substantial amount, 60% of patients, 60, experiencing either complete or partial remission. 39 complete remission and 39% complete remission and 18% partial remission in the group of aggressive non-Hodgkin lymphoma, which included, in addition to the LBCL, primary mediastinal B-cell lymphoma, mantle cell lymphoma, etc. And as far as the LBCL is concerned, 23% complete remission and 27% partial remission. Just to have a feeling on the quality of remission, this was the case of one patient presenting with a large extranodal mass of the leg. This was one of our patients, and after 2 cycles of therapy, which means 10 milligram plus 16 milligram of antibody, the PET was negative. This is a specific FDG activity due to muscle uptake. So this drug is really a very powerful and very potent and very active also in refractory patients. This is the duration of overall response, but the clinical setting is not designed to look at duration of response. Again, these patients, whenever it was possible, after responding, were consolidated by allografting. Mechanism. There is a sudden and quick peripheral T-cell activation, and here is an example. This is a tumor biopsy before treatment, and this is on treatment. There is a Ki67 tumor cells interspersed with T-cells, and this is associated with the appearance of T-cells killing tumor cells, and is followed by the appearance of necrotic cells in the tumor area infiltrated with activated T-cells. As a matter of fact, all these patients experience some degree of tumor lysis syndrome and mild CRS, cytokine release syndrome, grade 1, grade 2. No specific conclusion, but I just want to say that this is a very active drug, and we expect to have to complete now the expansion phase of the phase 1 trial and start phase 2 of combination with chemotherapy. And I have no specific conclusion, because then I think we can move to the other part on CAR T cells in lymphoma, and then eventually, if there is time, we can get some questions. No. Just relax. I have still to speak for 10 minutes, and I will try to skip to save time. Okay. This is the case. This is again the disclosure. CAR-T cells. Now, this is a very complex procedure. I just quickly summarize what is going on with these patients. Essentially, if you have a patient and is a candidate to CAR-T cell therapy, and if you have a slot and there is the availability of the clinical material, you can the patient will undergo to leukapheresis to collect lymphocytes. Lymphocytes are then isolated in the lab and activated and transduced with either a lentivirus or a retrovirus, depending on the specific product. These engineered CAR-T cells are expanded in vitro and then collected. They undergo cryopreservation, and then they are reinfused in the patient. But before reinfusion, the patient will receive a lymphodepletion or lymphodepleting therapy just to make some room for facilitating engraftment of T cells. As a matter of fact, after a reinfusion of these cells, there are two major clinical complications that may occur, and this is a general experience in using all the different CAR-T cell products. And these toxicity are represented by the cytokine release syndrome and neurotoxicity. Now, there is a lot of recent advances in this, because the major point that people have afforded in the US was the need to make an harmonization of the grading of CRS and the grading of neurotoxicity. And so I recommend to people interested in this topic to go back to papers published by the American Association for Blood and Marrow Transplantation. They just changed the name recently, but the major paper is published. There is also a major advance for those of you who are iPhone addict, because there is a mobile app called CAR-Tox. This app was developed at MD Anderson Cancer Center. Is a very useful instrument because you can grade the CRS and neurotoxicity, and you have in parallel a lot of suggestions for the treatment. This is something that all people dealing with CAR-T cells have to become familiar, because CRS is an early occurrence after a few days after CAR-T cells reinfusion, and the clinical presentation may be very aggressive with fever, hypotension, tachycardia, and liver and kidney toxicity, which essentially is the same toxicity that you detect in patients receiving bispecific antibody. And obviously, the intensity and the risk, the probability of toxicity is proportional to the level of expansion of CAR-T cells in vivo. The more the patients have a high tumor burden, the more the cells do expand in vivo, the higher is the risk of toxicity. Now, what about the product? There are three products. The first one is FDA and EMA approved, and this Kymria. The second one is FDA approved and EMA approved, and this Axicell or Yescarta. The third one is not yet approved, but will soon receive approval, people believe, and this is JCAR. These are from three different drug companies. The binding site of this chimeric antigen receptor is FM6C63, recognizes CD19, and it's the same for all the products. The costimulatory domain is 41BB for the first and the third, and CD28 for the second product. Bulk T cells are processed for generating this Kymria product and the Yescarta, whereas separate CD4 and CD8 are processed with JCAR. This is not only a technical matter, because CD28 or 41BB has a different impact on the function of these cells, in that products containing 41BB are expected to have a long-lasting expansion, whereas the in vivo expansion expansion that you get with when the costimulatory molecule is CD28 is much more early, is much early, and is not long-lasting. Now, quickly we can go through some clinical results. This is the Juliet trial using the Tisangen Lecleusel, and this is the Novartis trial using one of the three products, which has a name which I don't remember. But let's focus only a few numbers. 238 patients were screening for eligibility, only 165 were enrolled, but only 111 were infused. That means that the reinfused patients were 62 of the 100% start enrolled here. Manufacturing failure was involved in reducing the population of reinfused in 7% of the patients. All the other patients were not reinfused essentially due to disease progression. The overall response rate was 52% with a 40% CR rate. CRS grade 3 or above was 22%, neurotoxicity 12%, grade 2 neurotoxicity 12% of the patients. If you look at curves, they are really surprising and very inspiring, because the patients treated with this product were refractory or primary refractory or relapsed patients. As you can see here, progression-free survival in patients experiencing complete response has not reached the median, whereas in the overall patient population, all those not responding or experiencing partial response, they do progress, so the curve is below 30%. Duration of response. If you look at patients experiencing enduring response, you have the patients with complete response do have a 79% of duration of response at 12 months, whereas overall the duration of response is 65 at 12 months. Overall survival at 12 months is 95% in CR patients and 49% in all patients infused. And again, all these curves, the differences are related to patients who experience complete remission, they remain in response and they do not relapse. Vice versa, those who are not achieving complete remission, they progress. After a median follow-up of 14 months, the major point to me is that 30% of the initial patient population, calculated by intention to treat, obviously, has a durable response, which is surprising because these refractory patients are candidate to a median survival of 6 to 7 months, according to the SCHOLAR-1 study. So this is something that we have never seen before. Quickly go to the second product. This is the Yescarta. Again, a few numbers here. 111 patients enrolled, 101 reinfused. That means 91%. You can make an inference that the production was more efficient with Yescarta. Manufacturing failure 1%. Overall response rate 82, complete remission 54, grade 3 or more CRS 13%, grade 3 or 4 neurotoxicity 28. Here the toxicity values are higher, but the CR rate is higher also. Again, very nice progression-free survival curve at 2 years follow-up. The median is not reached for PFS in patients experiencing complete or partial remission, whereas patients who have stable disease, they do progress. Duration of response excellent for CR, the green line, median not reached. For partial remission, 2 months, of duration of response. And this is the survival, essentially at 2 years, 24 months, 51% of the patients are surviving, are in complete remission. So essentially 50% of these patients are surviving at long. Yes, it's a long term for patients with refractory disease. And this is it's an impressive result. This is very encouraging. This is the third product, the Celgene one. The data are not yet published, so I will skip all this story. And just this is a comparative table suggesting that the Celgene product is the less toxic. The efficacy results are very similar among all the 3 studies. And in any case, at this stage, it's very early to make any comparison, and we should start to use them and to try how they work in our clinical settings. In Italy, the situation is that we have 3 products. All 3 products are available, but with different indications and with different approach, because there is one, the Yescarta, as of today, is available only as a compassionate use. The Kimbria is available both in a clinical trial and as a commercial use under the reimbursement of the National Health System, and the JCAR is available within a clinical trial. There are 8 centers that are so far accredited for using CAR T cells, and this involves a number of institutions. I don't remember exactly which are them, but I only remember that the majority of them are concentrated in the northern Italy, which is a matter of discussion, obviously, but the Istituto Nazionale Tumori in Milano, Humanitas, San Raffaele, the Pediatric Institute in Monza, and then in Rome are already active, and a few other institutions will be active and enrolling very soon. Challenges. We need to increase the efficacy of the CAR T cells, because even the 30% or 50% long-term response is not enough, and to reduce toxicity and to overcome resistance mechanism. And this requires vector and chimeric antigen receptor optimization. So it's a matter of preclinical and, let's say, also basic science. We need to develop appropriate strategies for patient allocation in clinical trials. The question is, how do you, if you have a patient and you have to suggest offer him a therapy in a relapsed or refractory setting, how do you decide and how do you manage the patients to offer him CAR T cells or a bispecific antibody or ADC, an ADC antibody? This is a very critical question, because CAR T cells versus bispecific versus antibody drug conjugated is not my personal fantasy, but is based on data showing that in some type of patients probably CAR T cells are irrelevant, because, in particular because this is not easy to perform therapy. Then there are, so this is a problem for clinicians, and we need a lot of clinical trials and a lot of brainstorming. And finally, there are some cost-related issues. This is a political and regulatory problem, which is on the ground now. This is really the last one on accessibility, listing product, of cost of the product. This is important, but the other point to me is the production capabilities. 5 months ago, Novartis stated that they can produce 800 products, CAR T cell products for Europe. 800. In Italy, we have calculated we have 700 refractory DLBCL per year, and so we cannot use all the Novartis product, which is devoted to all Europe. So again, here there is a problem. Qualification and etc. This is irrelevant, and this was really the last. Thank you.
Okay. I think we have time for just a quick question, if anyone has a question. So I have a quick question. I mean, you I think very nicely pointed out that, well, thank you for two nice talks. That
So it was only one, it was a mix.
You importantly pointed out that the durable complete remission rate is fairly similar at 6 months between the 3 leading CAR T-cell therapies. And at least in the BITE, both the CD20 and the CD19, the CR rate at 6 months looks maybe a little bit less. And I'm wondering, what do you think is the best way to compare across all of these T-cell based therapies? Is it overall response rate, complete remission rate, durable complete remission rate, adverse events? We're going to have a lot of options, so how do we pick between the 6?
Actually, this is my major problem over the past 3 weeks, because we started having access to CAR T cells, and when speaking with patients, it's really very difficult. At this stage, we have to take into consideration, first of all, the availability of the product. So not all patients can be scheduled for a CAR T-cell program. And usually we make a few phone calls in the metropolitan area in Milano, speaking with colleagues at Cancer Institute or at San Raffaele Hospital, just to ask them if they have something ready to go or not. And the answer usually is no, because they have their own patient. And then we try to make a strategy with the patient to discuss with him a strategy, starting with the use of a bispecific antibody, and then following with CAR T cells, which I think is the only thing we are so far doing. And I'm willing to accept your suggestions or advice on this. How do you manage this? I think it's a problem that you also
Well,
have.
it's interesting. So I think one of the big questions now is if you use a CD19 therapy and that does not cure the patient, do you lose the possibility to use CAR T-cell later? And so I don't know what the answer to that is.
I don't know,
but
because in the ADCT trial, the phase 1, we had at least four patients who received CAR T cells after the CD19, and at least 2 of them responded. We have no information as to the expression of CD19. This is something that we will go back now. So it's not sure. I'm not sure that CD19 expression is lost after an anti-CD19. But
yeah.
90% maintained the CD19 expression, and they were candidates for CAR T subsequently. And when you're using ADC CD22 antibody, most of them maintain CD22 expression.
Yeah, so maybe that means
Yeah.
it's a weaker anti-CD19. In CAR T-cell patients who relapse, actually the majority of patients are CD19. The tumor is CD19 negative. So it kind of begs the question, if you use a good CD19 therapy or a better 19 CD, you're going to eliminate all your CD19. Possibly. I don't know. Yeah, I don't know if I know the answer. I could tell you in MD Anderson, when we're looking at we have 2 currently approved commercial products. I often will look at the side effect profile. So if a patient is a little bit older, I do think that the Kite Gilead product is a little more neurotoxic.
yeah.
So
obviously, also this type of clinical evaluation, looking at the patient who has to receive, is important, because based on age, tumor burden is another critical issue, and comorbidities and previous therapy and cardiac function and so on.
So thank you very much. I think in the
Thank you.
we're going to move on to the last speaker. Dr. Romano has been waiting patiently to tell us, I'm sure to give us a great talk on the microenvironment and its impact in Hodgkin's lymphoma.
Yeah, thank you, basically. And don't worry if we back a little bit back to the basic research in Hodgkin lymphoma, just to give you an idea that probably we need more information about those FDG positive lymphomas, because we can change a little bit their story. First of all, thank Professor Martinelli, thank Claudio for the kind invitation. I'm trying to go ahead. Sorry if I'm not so smart. Okay, yeah. So basically, in Hodgkin, we have a very important microenvironment component. And this is clinically relevant because we know that PET scan basically is related in a certain way to the role of accessory cells. And in particular, in our group, we are interested in the so-called myeloid-derived suppressor cells. This is a very long story, but just to make it very short, the idea is that basically you have hematopoiesis that could be affected by cytokines released by tumors. And in particular, in Hodgkin disease is very important because we could have an increase both in the bone marrow and the peripheral blood of neutrophil-like myeloid-derived suppressor cells. Neutrophil-like means that the morphology is like neutrophils, but the function is completely different because they are immunosuppressive. There are different ways to measure myeloid-derived suppressor cells in peripheral blood and bone marrow, and basically after a very long discussion in the last years, one of the best ways is to look at the expression of LOX1 using the whole peripheral blood, and also using the new definition, not only the functional and phenotypic definition of MDC, we can say that Hodgkin patients basically have a lot of MDC, and this is related to the clinics. It's not only my idea, because on the top you can see the numbers of our group, but also several different groups in the world are showing basically the same data. The most interesting point is that you can say a diagnosis that if patients have a lot of MDCs, and you can use also different cutoffs based on the way you can measure, basically you can predict the outcome. It's not so specific, it's not so sensitive, you still need to use PET scan, but at least it's something that you can have very quickly a diagnosis. So the point is that very interestingly, in Hodgkin disease, is that in the microenvironment, macrophages, and this is very strange, it is so typical of cancer and not of the healthy counterpart, the macrophages can overexpress in the same cell IDO and arginase 1. In a while, I'll explain you why this is very important, but the point is that these macrophages not only are associated to tumor, and not only they are clinically relevant, but also they are immunosuppressive. Immunosuppressive against T cells, and T cell function is crucial, especially now that we are trying to use immunotherapy more and more. And basically, just to say why we are talking about these two amino acid degrading enzymes that are typical of the biochemistry of MDC. First one is arginase 1, that is on the top. Arginase 1 is able to convert arginine to urea and ornithine. Why we are so interested in the levels of arginase 1? Because basically when T cells don't have enough arginine, they can't proliferate and they go very quickly to apoptosis. And the same can be performed by indoleamine deoxygenase 1, which is the enzyme that can convert tryptophan to kynurenine. And again, when you have a lot amount of kynurenine, your T cells don't work properly, and T cell receptor cannot be made properly. So basically, we know that our patients have a lot of MDC, our patients have a lot of these enzymes, there is a reduction of amino acids. We can say, okay, it's very interesting, we can use them as biomarkers. Our idea is that we can do a little bit more. And more means that we could understand better the role in mediating fitness of neoplastic cell in this specific environment. The point is that probably, it's the novel idea behind our project, that basically the neoplastic cell can take advantage twice of this specific environment. The first point is because these cells are not working properly, so you can promote immune escape. But at the same time, you can also arrive in a condition in which you can change your metabolism and you can change also the proliferation rate. The point is that there is a sort of adaptive response to the reduction of available amino acids that can be used to change the response to the environment, I mean to the biochemical environment. Earlier this morning and this afternoon, we knew that basically this can happen in different settings, in leukemia or in other hemomalignancies. And the crucial point is that these cells, when exposed to the reduction or starvation of arginine and tryptophan alone or in combination, can increase both two ways of energy production. The first one is glycolysis on the top, so it means that can take more glucose, but at the same time can produce more OXPHOS. And it's interesting to notice that the activity of IDH1 that is not mutated in Hodgkin disease is just the normal enzyme that can work more or less based on the kind of biochemical environment. The effect is more important for arginine deprivation for IDH1, and while the effect is the same for arginine or tryptophan deprivation based on IDH2. And so basically there is also another important change that is related to the shuttling of malate and citrate that is crucial for the correct mitochondrial functioning and also for the synthesis of new structures that are required, for example, for proliferation. So to make very short the story, we found that mitochondrial mass can increase in deprivation of amino acids, and this could help to produce more ATP, not only because we measure more ATP, but also because we have more machinery to do ATP. And also, we have a change in the dynamics of mitochondria that is crucial for resistance to drugs and also for the resistance to redox stress. I mean that we have more fission and less fusion, just to skip all details because we don't have time to go deeply that. And just to summarize our first preliminary data is that mitochondrial adaptation can take in account two ways. The first one is an increase in glycolysis, and the other one is an increase in OXPHOS. But the point is that when you increase OXPHOS, you can manage differently lipids, so you can synthesize differently your membranes, so you can have more machinery to proliferate and probably also to become resistant. Since this is happening in an environment that also is promoting immune escape, this is a double way to promote, the disease itself. Just to give you an idea of what we are really looking when we see a positive PET scan after 2 or 3 cycles of first-line treatment. When we found a patient with a negative PET scan, we didn't cure the patient, of course. We are just reducing the metabolic changes occurring in the environment. We are reducing MDC because it's something that we previously showed. That probably we are just changing the metabolism, since sometimes we don't have idea what we are really looking when we are use our imaging. Probably it's what we are basically trying to work. So it means that we could work on different trackers for our imaging, especially when we have this kind of changes in the environment. So before to take your questions, and I hope to be really happy to take your questions and give you an answer, please let me thank all people in Catania that are working on this project, in particular Fabrizio Pulisi, who is the PhD student that did large part of this work. Thanks again.
So very nice. Thank you for a very interesting topic. And about that, the last slide about PET imaging, I mean, what would you suggest as an alternate for PET imaging? And if
Okay, we have some ideas about that. Basically, because of course we are using glucose when we perform PET scan, right? We could change in glutamine, for example, or we could change also in arginine. That is our idea. We have some trackers that we are trying to modify using mice. The point is that we don't have good lymphoma mouse model right now just to test the idea, but the point is that you can modify. It's also something we are doing in the myeloma, for example, because we are using CD38 active, so you can see where the disease is. In this case, we propose to look where the dangerous environment is. if there
Okay.
is any trial.
So next time you can come and present some mouse data with the new
definitely, I
glutamine
hope so.
target. So I think in the interest of time, we're going to wrap up the session. I think we heard some great things about Hodgkin's and some wonderful cellular therapy talks. And thank you everyone very much for your time. And I think this is our last session, right? Excellent. Thank you.
Thank you. Thank you very much. So, no need to present Elias. Please.
Thank you very much. Sorry, we're rushing you for questions, but the faculty are all here today and tomorrow. So just to be on time, we moved to CML, and I'm honored to co-chair this session with Professor Saglio, who's local and who's well-known. So how I teach CML, resistant disease and novel combinations. So far we had 16 randomized trials up front, and none of the trials have shown a survival benefit. They all have shown deeper, faster responses, achieving milestones earlier, maybe stopping therapy, but none of them has shown a survival benefit, and that means we have today in CML a very good salvage approach. It's really important to monitor your patients, not too much, not too little. CCYR remains gold standard for survival benefit, but we're moving into another step of what we call stopping therapy and the importance of inducing what we call complete molecular remission. So it's simple. We have to monitor our patients, and we see a lot in the USA at least, patients refer to us because the PCR is changing ups and downs. Well, minor changes are okay, should not affect your treatment changes. So if the PCR is coming down, that is excellent. If the PCR is stable with minor change, that is okay as well. You do not need to switch therapy because somebody had minimal disease. Unlike what you've heard in AML, unlike what you will hear tomorrow in ALL, in CML, minimal disease does not compromise survival. No, if you have a PCR increasing by more than half a log to 1 log, check compliance, and then of course, you have to check for mutations, get the workup done, and decide on next therapy. 3 months or 6 months. Patients at 3 months who did not achieve a 10% threshold, as recommended by the ELN and CCN, will monitor till 6 months. Those who achieved the 6 months 10% or less had an outcome similar to early responders. Therefore, changing at 3 months is controversial. I think we should not assess the disease in a static way. Rather, we should look into the disease response in a dynamic fashion. There was a study that was presented in abstract format last ASH meeting called the Sessione study, where patients who did not meet the 10% milestones at 3 months were offered to be randomized to either dasatinib or imatinib dose escalation. Of course, the primary point was the achievement of a CMR. Switch did improve responses, but at the long run, there was no difference in overall survival nor in progression-free survival. Therefore, you can wait till 6 months and make the change accordingly. So 6 months first milestones. The 12 months milestones is important. You need to induce what we call CCYR. Regardless of how you get there, if you achieve a PCR of 1%, you have a better outcome, better survival, compared to a patient who did not achieve a 1%. So 10% at 6 months, 1% at 1 year. For survival, however, the achievement of a deeper response, MMR, more or less, did not impact the outcome, provided the PCR is 1% or less. So the ELN is about to change their criteria for responses. I'll still follow what was published so far in 2013, where 10% at 6 months for me is a failure, 1% at 1 year and beyond. These are the milestones we follow in our practice today in the USA to change therapy. So I change therapy. What do I have in the second line? The options are listed here. Dasatinib, nilotinib, bosutinib. Ponatinib is approved at 45 milligram per day in patients who failed second-gen TKI and or acquired T359 mutations. Although the label is for 45 milligram, I never use 45 milligram in chronic phase. I usually start on 30 milligram and reduce to 15 in order to avoid the risk of complications, mainly vascular ones. In the second line, we did an exercise where we look at the 620 patients who received dasatinib, nilotinib, or bosutinib, or others. Half of them switched therapy due to failure. In a second line, median follow-up of 50 months, the rate of CCYR in a setting of failure is 50%. For outcome, for survival, it doesn't matter which TKI you choose. All of them are equivalent. For event-free survival, nilotinib seems to be weaker than dasatinib or bosutinib in our series. So how do I choose, therefore, in a second line? Of course, disease characteristics are to play a role. Somebody who's progressing to blast phase, I favor combination of chemotherapy and TKI, and my best TKI is ponatinib, and we'll share some data tomorrow morning. I favor combination, I go for transplant. Chronic phase disease, I check for mutations. Our standard of care is still Sanger technique, although NGS is gaining momentum. 359 is ponatinib. Then I will choose my second-gen TKI based on my mutation profile. For example, F317L, I will avoid nilotinib. I will go for F317L, I will avoid dasatinib, I'll go for nilotinib. Somebody who had F359, I will avoid nilotinib, go for dasatinib or bosutinib. But then, something quite important in CML is comorbidities. The median age of our patient is 65. A lot of them are either smokers, like in Middle East. I see a lot of smokers in Italy as well, unlike USA. Or in USA, obesities and vascular problems. These are important elements that will help me select my next treatment. Somebody with COPD, I will avoid dasatinib. Somebody with the vascular risk factors, I will avoid, of course, nilotinib. In our experience, bosutinib seems to be the most tolerable TKI from the cardiovascular profiling, although it does cause diarrhea, highly manageable. So maybe it's good to give it for a patient with constipation. Too expensive for laxative. I think you're tired. This was a joke. Okay, so when do I go for transplant? Progression, advanced stage disease. Today's standard of care is combination of chemotherapy and TKI. Get a good response and then go for transplantation. Somebody who failed imatinib therapy, acquired 359. Ponatinib is my standard of care, and I will only go for transplant if ponatinib is not working anymore, or somebody had a problem with ponatinib or had the vascular issues. Somebody who responded to imatinib very well, lost his or her response, I go for second line, and I will try ponatinib third line before I go for transplant. Now, you can have a scenario where you have somebody who had a compound mutations, mainly 359 plus something else. These are patients who do not do well even with ponatinib, and I think transplant should be offered faster than later, earlier than later. And finally, older patients. You know, we get patients referred to us because they're 78 years old, and then, well, they failed TKIs. And they take them off TKIs, put them on hydroxyurea. Well, they will have still a good survival on TKIs, even if they have not achieved the deepest response possible. So keep them on TKI. You know, in medicine, when we took the oath, we said, first of all, we should not harm. I think for somebody who's 80 years old, transplant should not be offered, nor something more aggressive than that. Ponatinib is a very potent BCR-ABL inhibitor, a multi-kinase inhibitor. It does inhibit multiple kinases, among them PGFR, VGFR, c-KIT, FLT3. The drug was tested in a phase 2 study, multi-center trial in patients who failed multiple TKIs. 49 patients treated, 270 in chronic phase disease. The rate of response, measure cytogenic response, which is the primary endpoint of the study, was achieved in 60% in chronic phase, MMR 40%, and a 5-year survival 73%. That tells me today, should I go for transplant in patients who failed 2 TKIs? The answer is no. I think they should get ponatinib or other agents, as I will show you in the next few slides, and keep transplant for alternative approach. There was a concern about ponatinib, and there was a concern about vascular events, whether we dose reduce, we provide better treatment value. I think so. In fact, we know that the vascular events decrease with time, and that decrease is due to the dose adjustment. We rarely give somebody in chronic phase more than 30 milligram and 15, most of our patients. In the third line therapy, we had a similar analysis like we did with the second line. And in a third line, the rate of CCYR is 40%, and ponatinib stands at the best TKI in a third line. Therefore, in our practice today, we do not rotate second-gen TKI. Once I have a failure, used imatinib first, nilotinib or dasatinib or bosutinib, I go to ponatinib as a third-line treatment. So there are several drugs being explored right now. The most advanced one is asciminib or ABL001. It's a cousin for James Bond. No, 007. So the drug is an allosteric inhibitor of BCR-ABL. It's very different than the previous TKIs we've used. In a way, it binds and it enables the BCR-ABL oncoprotein. The drug has shown activity in extensive phase 1 study, and I will show you some data. And the drug is being assessed right now in a pivotal randomized trial for phase 3 in patients who failed 2 TKIs are being randomized to bosutinib or asciminib. Radotinib is approved in Korea. It's similar to nilotinib. It's not approved in the USA nor in Europe. But then there's several compounds that are being explored right now in a phase 2 and phase 1, PF114, HQP 1351, and the K0706. These are multi-kinase inhibitor with hypothetical advantage compared to ponatinib. They do not inhibit VEGFR, and therefore they may not cause vascular events. These are ongoing. Asciminib or ABL001 had extensive phase 1, different dose schedule, combination, single agent, 359 cohort, non-359, advanced stage of chronic phase. The drug is active. Responses were seen early on, 75% CCYR rate, and even molecular responses were seen. And there was interest to see whether the drug will be active in 315I mutation patients, whether they received ponatinib or not. And here you see the responses. By 48 weeks, all patients, 80% achieve a CCYR, which is good. And if we look at the molecular response rate obtained in 315I cohort at 200 milligram BID, approaching 38%. So this drug has promising activity, and we're awaiting the approval eventually of the drug. Advanced stage disease, chronic phase, we're doing great. Advanced stage disease AP, we're doing great as well. The blue curve, we have a survival 80%. In contrast, in blast phase, even though we had a lot of progress in chronic phase, here we did not make any progress. The best thing today is to prevent transformation. Blast phase disease, we reviewed our series, almost 500 patients treated, median survival 12 months. What matters for the outcome is a lymphoid transformation, a combination of chemotherapy and ponatinib, and transplantation and ponatinib post-transplant that offer the best chances for long-term outcome. What's new? We know that BCR-ABL cells, they come with overexpression of BCL2 and MCL1, what we call the anti-apoptotic protein. Therefore, the hypothesis is if we combine BCR-ABL inhibitor with ABT199, we can not only suppress the BCR-ABL cells, but the quiescent stem cell, the progenitor stem cells. So in Houston, we start by giving dasatinib upfront with 50 milligram per day, half of the dose. Interestingly, with this combination, we had an MMR rate of 80%, which is superior to what you can see with 100 milligram. Why so? Because we have a better exposure, minimal interruptions. And that will leave us room to combine venetoclax plus dasatinib. So today we moved into a combination with the frontline, dasatinib 50 milligram per day, and at 3 months we add venetoclax 200 milligram per day, 14 days every 28 days. And the aim is to really use high CMR early on and be able to stop the therapy within a year or two instead of giving it 2 or 4 years of treatment. The study is ongoing. We have 28 patients treated. The results are promising, but still too early to share with you some data. To build on this hypothesis, we as well designed a regimen for blast phase disease where we give ponatinib in combination with venetoclax and decitabine to control the blast phase myeloid, and the lymphoid we reverse. We do dexamethasone and venetoclax instead of decitabine venetoclax. These studies are ongoing at MD Anderson right now. So in summary, we have great therapy for CMN in frontline. They're getting better, safer, and cheaper. I hope so, not in the US, but hopefully in Europe, and hopefully soon in US. Second line option, I think they're all equivalent. Third line, ponatinib is the best one we have today. We're exploring newer ones, hopefully safer. CCYR or 1% PCR should be an endpoint for survival. Aim to change therapy at 6 months, at 12 months. Those reductions are effective and safe in most instances. TFR is the reality, but only for a few patients. You should take into account biology and the depth of the response and pay attention to patient comorbidities. Thank you very much for your attention.
Thank you, Elias. Questions?
Yes, Dr. Martinelli.
The new ponatinib, you mentioned, is very similar to ponatinib. Why you say that?
Well, the profile, well, the activity against BCR-ABL sin is very potent. Therefore, in a 359 mutation, it does suppress this clone emergence. Why? This is similarity between ponatinib and the newer TKIs. Although for other kinase protein, the profile is different. And therefore, the hypothesis is therefore we can suppress 359 at a very low nanocluster IC50 without causing the vascular problems.
Because our gene expression profiling showed that ponatinib is totally different from other TKI that we know, and probably the RIP-kappa1 and necroptosis activity will probably make a difference, as I mentioned. Okay. Probably.
Of course, I heard you.
And I was searching in since the ponatinib is coming out from license in 2027-28. Sometimes the company doesn't take, if they don't have sufficiently time to make additional searching for indication and getting time to get a registration, they don't invest. So I'm searching for a similar compound, but there are not too much similar to this ponatinib. Sometimes the efficacy of the ponatinib probably not immediately related to the activity on BCR-ABL only.
And we see this activity in ALL in pH positive, where beside the BCR-ABL sin, it does suppress every clone you can ever imagine. So I agree with you. Thank you. Thank you. The next speaker is Professor Beppe Salio, who will enlighten you on the CML in Italy.
Thank you very much, Elias. So I will say about my, not my personal experience, but the experience of the Italian centers. As they appear from the CML Italian registry, which is a project that started a few years ago. You may see that there are 68 active centers all over Italy, and more than 2,000 patients have so far been enrolled. These are quite not updated data, but however, they tell us that there is a good accrual, but we have limited this analysis to 1,200 patients who have at least 24 months of follow-up. The first data that we can have, this is just to have a picture of what is going on, what is the outcome of the CML patients in our country, because I think that this is, I would say, a sample which represents approximately 80% of all the CML patients that we have in Italy. And as you may see, the first information, rather important, is the median age of the CML patients, which is definitely higher with respect to what we have in other countries, young countries like China, India, and so on, is 58.5 years, and also a little bit higher with respect to what we have in clinical trials. And this means that we are not selecting for a specific population of patients. What is important is that certainly the Italian doctors, which are working at least in the centers, but which are covering approximately 80% of the patients, indeed are taking very care of the diagnostic workout. Indeed, all the data before any kind of therapy, because it is definitely allowed us to say exactly, to establish the SOHO risk as well as all the other risk scores which are presently available. As you may see, it's important to note that we are progressively moving from the traditional SOHO to the European long-term survival score, which is really a very good score because it clearly decreases, and we will see later on why this is important, the percentage of the patients in the intermediate and high risk group with respect to what we have with SOHO. And this is mainly due because the scoring system is weighting a little bit less about the age of the patients. Certainly there is a very good, I would say, the opinion of the Italian doctors is to collect cytogenetic data diagnosis. As you may see, a very high percentage of patients have a cytogenetic analysis at diagnosis. And this is important because approximately 10% of the patients, they have additional chromosomal aberrations that we know may impact also on the outcome of the patients. We are still to verify this point in this specific collection of data, but we will do it, and I'm sure that we will find what has been already confirmed in several papers in the literature. Of course, there is a qualitative PCR, and this is essential to see if there is one of the traditional fusion transcripts, which are typical of the chronic phase SML, or if there are few cases in which there are non-conventional, I would say, for the chronic phase fusion transcripts, which of course require a different way to monitor the response of the disease to TKI. But Italian hematologists generally also consider very well all the aspects of the patients, in particular also the risk in terms of cardiovascular events, the risk of other presence of other comorbidities and so on. And you may see that a little bit more than 75% of the patients, indeed, they do not have a Charlson comorbidity index higher than 0, and there is, however, a small group of patients, approximately 10% of all patients, who have a higher comorbidity index. So this is mainly due to cardiovascular diseases, but also to lung diseases, as well as metabolic diseases or other forms of comorbidities. How we treat this first-line therapy, and this is a very important picture, because in the last, we would say, 4 or 5 years, indeed, we are treating half of our patients with imatinib as first-line therapy, and half of our patients with second-generation TKIs. The choice is based certainly on the fact that the second-generation TKIs are really effective, particularly in producing a faster and deeper molecular response, but also more toxic. And you may see that the median age for patients with second-generation TKIs is 52, much lower with respect to the patients who are prevalently treated with imatinib, which is 66 years old. Now, when we decide to change the treatment because of failure of first-line therapy, I would say that now there is, in these days, a big discussion among all the persons who are involved in the, I would say, writing the European Leukemia Net guidelines. I would say GMEMA CML Working Party has established this table, which is a little bit different with respect to what it has been published time ago. In fact, we have eliminated the term warning. Now it's a non-optimal response, and we have defined the failure resistance in a very clear way. The major difference, however, is due to the fact that this, with respect to what our colleagues of the MD Anderson are thinking, is that for us, if after 2 years you are not in a better position than MMR, probably this is a warning situation in which you may decide also to change the therapy, whereas I think, and we would like to discuss with you, then your position is different on this point, I think. No? And this is a different vision about what we have to achieve. So when we decide to switch according to the table that we have seen before, indeed we are moving, if we are starting with imatinib, we are moving from imatinib to a second-line therapy, mainly represented by nilotinib, dasatinib, but also bosutinib, which in Italy is registered as a third-line therapy, when nilotinib or dasatinib is not indicated. And there is a trial now in Italy, just testing which is the best dosage of bosutinib to start with. Indeed, this trial is progressively increasing the percentage of bosutinib from 300 milligram to 400 milligram, arriving to 500s only for those cases who are not showing a good response. Ponatinib, even in second line, is indicated for patients with the 359 mutation. As a third line, we can change the other second generation TKI, but generally nowadays we are moving directly to ponatinib, and for some patients we can start to consider stem cell transplant. As a fourth line, we have only stem cell transplant at the moment or investigational therapies. For patients who are intolerant, which are starting with nilotinib and dasatinib, which are intolerant to second generation TKI, as second line, fortunately, the number of patients who are failing these two types of therapy are few, but there are, however, a consistent percentage of patients who are simply intolerant. We are changing to the other second-generation TKI if it is possible and indicated, or we are using bosutinib that is, from the toxicology point of view, better tolerated with respect to the other second-generation TKIs. As a third line, we have ponatinib. If we are starting for nilotinib and dasatinib, in the few cases which are resistant, generally we are moving to ponatinib immediately without changing so many therapies. And as a third line, we are using, we can consider stem cell transplantation is possible or investigational therapies. Now, the overall survival with this approach from the therapy is very good. You may see that is almost 96% with a median follow-up which is not very long for the moment, but already quite interesting. It is important to see that apparently second-generation TKI have a better overall survival estimate with respect to imatinib, but this is mainly due to the age of the patients, because most of the deaths are CML-unrelated deaths. So we do not fear so much. There are progression in early phases of the therapy of the disease, but they are not so frequent as reported in the literature, at least in the Italian population. What is important that going back to what I said before, if we use, I would say, the overall survival in distinguishing the different groups according to the SOHO risk, we have a very little difference between these two groups. But if we are using the LTS risk, you may see that it better distinguishes the difference between the two groups. In particular, we have the high-risk group that in the LTS risk scoring is limited in percentage of the patients, and of course is not so much influenced by the age of the patients, which are doing clearly not so good as the other two groups. And if we are using imatinib, the distinction between these three categories remains. What we have found very interesting is that if we are using second-generation TKIs, the intermediate group behaves exactly like the low SOHO risk group. According to the molecular response, you may see that the difference is remarkable when we are considering the first few months from the start of the therapy, if we are using imatinib or if we are using second-generation TKIs. But as many patients with imatinib, many means approximately 35%, because of intolerance or because we are moving to second-generation TKIs, indeed you may see that this difference later on in terms of MMR, in this case, remains almost invariable for a quite long period of time. It is very important also for MR4, which is the prerequisite of the deep molecular response, which is important, of course, for discontinuing the therapy. And again, you may see that during the first months of therapy, there is a clear advantage for second-generation TKI, which are producing faster responses, but later on, after 2 years, the difference between the two groups in the intention to treat analysis are not so dramatically different. So, big question at the moment, we are we are speaking mainly of TFR in clinical practice. Are we ready, or are Italian hematologists ready to, I would say, to perform or to start, to attempt a TFR for the patients? Well, what we have performed is an observational study together with many groups in Italy. And you may see that almost 300 patients have been collected, where all, this is a spontaneous discontinuation, or, of course, in most of the cases was decided between the doctors and the patients. In some cases, because there was a precise request of the patients. And you may see that indeed the major difference between is that all the patients were in a deep molecular response, and most of them also with undetectable transcript. And the duration of the TKI therapy was longer for imatinib, of course, with respect to what we have with second-generation TKI, or the patients immediately treated with second-generation TKI. But you may see here that indeed the time to DMR was definitely shorter, almost half in terms of months with second-generation TKI with respect to what we have with imatinib. The duration of DMR also, but you may see that apart these differences, we have a rate of relapses which is definitely, apparently, a little bit better with respect to what we have in the literature, accounting for almost 60% of patients who are remaining in TFR. And even if the reason to restart the treatment were quite variable according to the doctor decision, in some cases loss of MMR, in few cases also doctors were waiting for the loss of CCYR or other. The overall median time to restart the treatment was, however, 6 months. 75% of the patients restarted treatment by the first year. This means that there were also cases with late relapses. And indeed, one relapse occurred after almost 10 years of continuous TFR. The outcome was, however, good because no progression occurred. There were deaths, but these were not related to CML. Almost all the patients regained MMR after restart of the therapy, and 82% of the patients were again achieving a level of DMR, also duration of DMR, which was allowed, which could allow them to try again to achieve DFR. These are the two curves. They are, yes, the two curves are showing us, these are fortunately different months, that, however, the difference between what we can obtain with imatinib and second generation at 12 months is really modest. And also in the longer follow-up, it remains approximately the same. But what we know is that certainly we can obtain these results in a shorter period of time and in a percentage of patients who are achieving the condition to start the therapy definitely lower. These are these are the group of patients who have participated, and this is thanks to all the participating groups. Thank you.
Thank you very much. For the sake of time, I want to skip the questions. Maybe we can discuss at the end and move to the next talk, will be TFR, Impact of Death and Duration of Response by Professor Russo.
Thank you very much, in particular to Giovanni for the kind invitation. Very briefly, this is the title of my talk, and what about the impact of death and duration of the response? The first results on the effects on discontinuation of TKI treatment in CML patients were published and reported by the French group in 2010. And in this pivotal study, in this pivotal study, 100 patients treated for at least 2 years with imatinib, and in a complete molecular response, that means MR5 undetectable, it's comparable with this level, discontinued the imatinib therapy, and 60% of them lost the molecular response, and 40% maintained the complete molecular response. In this study, the factors influencing and positively correlated with the treatment-free remission were the sex, the male sex, the low-risk SOHO, and the imatinib duration more than 50 months. After that, many trials exploring the treatment-free remission have been done, and moreover, the discontinuation and the treatment-free remission strategy moved from the experimental setting to the clinical practice, that means in the real life, as you can see. Taking into consideration the last 5 years, about 2,000 patients were enrolled in 12 trials. The median age was 55. Almost of them received the second generation TKIs, and the minority the imatinib in first and second line. All the patients were in deep molecular response 4.5, and many of them in 4.5 undetectable. The duration of the molecular response at the enrollment was very heterogeneous, from 12 months to 30 months. And at 12 months, at 1 year, the treatment-free remission, with the exception of this study in S-Freedom, ranged between 40% and 67%. In the same period, about 700 patients were reported in 4 trials. Sorry, Beppe, I don't cite the last one. The most of patients, almost patients, received the imatinib, and the minority, the second generation TKIs, either in first and second line. Half of them were in MR4 and half in MR4.5, and the treatment-free remission at 1 year ranged between 45% and 74%. So, what we say about this experience in the controlled trials and in the real life? The patients who discontinued the TKIs in the controlled trials were 3-fold more than those of the real life. These patients were younger, and almost all were treated with second-generation TKIs, and discontinued the treatment when they had a molecular response of 4.5 or undetectable. On the contrary, in the real-life study, the great majority of patients were treated with imatinib, were in MR4 deep molecular response, and the median duration of this response was longer. Therefore, the two settings of patients are not comparable. So we tried to make a correlation between the depth of the molecular response and the duration of this deep molecular response, the blue bar, with respect to the rate of treatment-free remission reported, the red bar. But we didn't find any correlation between these parameters in relation to the treatment-free remission rate. So we can summarize that the TKI discontinuation and also the treatment-free remission in patients with deep molecular response is a strategy that is safe because the patients who lose the molecular response, as I have seen before, may rescue the previous molecular response. However, the treatment-free remission ranges are very wide because they range between 40 and 70%. It may seem that the deeper, longer molecular response better is the treatment-free remission. But we have seen that there are no correlation, and no correlation has been found between these parameters because the treatment-free remission is unpredictable. And for us, the main reason, or one of the main reasons for that is that the quantitative PCR is enough sensitive and accurate to measure the low levels of minimal residual disease. We have seen that the most patients who underwent TKI discontinuation had a molecular response of 4.5, but were undetectable. What means undetectable, I don't know. For me, is a black zone. So let me say, as a paradox, it's like we are driving a powerful car without knowing the optimal speed to reach our final destination, that is the treatment-free remission. This slide shows the limits of quantitative PCR, while this shows the advantage of digital PCR. More sensitivity, more accuracy, especially for low levels of target. The digital PCR allows the absolute quantification of the transcript. In our lab, we use the Thermo Fisher platform for measuring the absolute number of BCR copies for microliter of reaction. And during the last 3 years, and in 2 consecutive works, the papers, we comparatively analyzed with quantitative and digital PCR more than 800 samples, and we studied more 260 patients with major deep molecular response under treatment with TKIs. The major point of our observation are the following. We observed that the number of BCR-able copies measured by digital PCR for each patient within each molecular class are highly heterogeneous and are widely dispersed. And we try, by a ROC curve analysis, to identify a cutoff. We identified this cutoff, 0.468 BCR-able copies, that is equivalent to 6 copies of transcript, and the patients who had less than this cutoff segregate within the patient with a true or real deep molecular response. In this last study, we monitored by quantitative and digital PCR for at least 24 months to 2 years, 142 patients with deep molecular response from MR 4.0 to 5. And 111 of these patients stopped the TKIs. So we have seen that the patients with digital PCR less than 0.468 copies at the time of the discontinuation had a significantly higher probability to maintain a treatment-free remission, 80% versus 50% at 2 years. So the positive predictive value of digital PCR was 80% versus 47% in the case of the quantitative PCR. By univariate analysis and multivariate analysis, we found that the digital PCR and the DMR duration of more than 5 years resulted correlated with treatment-free remission. But in the case of the multivariate analysis, only the digital PCR retained its significant value. We observed also that the patients with less the cutoff 0.468 copies showed a more stable course along the period of the monitoring that was more than 2 years. This course and this behavior was not significant different from the patients, but the difference is not significant but impressive. Our results, which are partially retrospective and in part prospective, were observed and confirmed in this last recent paper by the French group, who reported the results of the prospective study STEAM 2, and the French group seen that the digital PCR, in this case the droplet digital PCR evaluation and the TKI duration and not the deep molecular response resulted positively and significantly correlated with treatment-free remission. In other words, the patients with digital PCR negative or less than 0.0023 showed a lower probability to lose the molecular response and vice versa, to maintain the treatment-free remission. So, in conclusion, the depth and duration of deep molecular response, and I can add the duration of TKI therapy, are important factors influencing the treatment-free remission. Concerning the depth of molecular response, quantitative PCR is inadequate to detect and monitor low levels of BCR transcript. By now, several retrospective and also prospective studies comparing quantitative and digital clearly show that digital is more sensitive and accurate to measure low levels of BCR transcript. So in the era of the more potent second generation TKI, digital PCR for us should become the gold standard method to manage and to personalize the therapy in CML patients. The most important open question is the standardization of digital PCR platform, and the alignment of different platforms should be carried in the future. Finally, I would thank all my collaborators, in particular Simona Bernardi, who is the head of my lab, and all the centers that in this year collaborated with us to generate these results. Thank you.
Thank you very much, Domenico. Are there burning questions? Please.
So, Beppe, I know you and I may disagree on what is frontline therapy, and we have our positions, but I think it's important to discuss it in an open meeting. I have not seen a single piece of evidence that suggests that second-generation TKIs upfront are better than generic imatinib for the sake of patients. So today, generic imatinib is about $3,000 a year. Second-generation TKIs are $40,000 or more in Europe, $150,000 or more in the United States. As far as survival is concerned, the survival is identical on average, provided you intervene at the time of loss of cytogenetic CR. As far as treatment-free remission, we just published in Lancet Oncology that it is very poor treatment value to use second-generation TKIs upfront if you want to aim at a treatment-free remission, and nobody mentions this in their slides. So I'm wondering why do the CML experts still advocate for second-generation TKIs upfront if survival is the same, if treatment remission is of poor treatment value with the prices today? Why not just all of us state that generic imatinib from a good source is the best strategy for patients in general?
But I agree with you, but I haven't discussed the first-line therapy of CML. My talk is focused on the relevance of depth and duration of molecular response, and not on the decision to use the second generation TKIs in first line. Regarding this point, you're right, and I agree with you.
We frequently discuss about these points and so on. You're perfectly right that at the moment there is no clear evidence in favor of second generation. But why, is a provocative question, are you trying to use dasatinib 50 milligram plus venetoclax as first-line therapy for CML patients?
Because we get dasatinib free at our institution, as opposed to generic imatinib, which at our institution is $20,000 a year.
Independently if it is free or not free, if it is useless, why do you want to try it? I would say venetoclax is also, we do not know so much about the toxicity. Apparently it's a very safe drug. But however, for a first-line therapy, according to the survival and so on. So it seems to me a little bit, once is definitely what we can recommend at the moment to the vast audience, particularly in countries which have economic problems and so on. But it's clear, and you are an example of this, that because you are the first to push for second generation TKIs, I've seen your data many times, so we say the MD and so on. Now, I'm very interested, I find your protocol extremely interesting, but why you are pushing if you do not believe so strongly in TFR? Once is the recommendation for treatment, I would say in one case, and the other one is from the experimental point of view, which expresses what we want to achieve.
Well, just to add to Dr. Kantarjian for the dasatinib 50 milligram, I think the concept of BCL2 inhibition and TKIs to induce TFR is very different from BCR-ABL inhibitor alone, because we know that BCL2 can go to the progenitor stem cells, and eventually, that is hypothetical. The study is ongoing. We may be wrong, but we may be right. The study is ongoing. With a short treatment of a year or two, we maybe get to eradicate the stem cell and cure this disease.
I'm not discussing the validity of the protocol,
but
that I like it very much. What I want to remark is that you are indeed aiming to achieve a better molecular response and to achieve so this is definitely our new goal in CML therapy. That at the moment is convenient to start with imatinib is perfectly acceptable. That in the future maybe we will start with dasatinib 50 milligrams, which is becoming also generic, plus venetoclax, which will become generic in a rather long time, I would say.
However, 1 week ago in Bordeaux, there was the ASH meeting, and one of the more exciting for me, that I'm a part of CML now, so I take just a look at the CML. One of the more interesting presentation was from the Australian group. They showed that the majority of the BCR-ABL persisting during MR4 or MR4.5 was related to the expression of BCR-ABL in lymphoid population. So the lymphoid population not the myeloid population, persists a bit of transcript. So in my opinion, it's a good idea to use venetoclax since BCL2 can be able to rescue a bit of this residual MRD and probably also in leukemia stem cell very high, which is probably not eradicated. That's my comment. But at this point, why not using ponatinib plus venetoclax also in CML as a potential eradication of the disease?
Too toxic. But let me make a final brief comment. The analogy is CLL. CLL was incurable. Now we know that with ibrutinib venetoclax for 2 years, even though they are costly, we can probably cure not functionally but molecularly most of the patients with CLL. We hope so. There's data to that suggestion. So if in CML we can develop a strategy with a combined expensive 2 drugs that could potentially cure CML, not functionally but molecularly, stopping treatment after 2 years, then it will be worth it. So that's the purpose of the dasatinib 50 milligrams venetoclax, but we do not know that this is doable, and it is somewhat toxic. But that's why we embarked on the dasatinib venetoclax. If we can, with a finite duration of 2 years of therapy, achieve complete molecular responses which are durable, so not do 5 or 10 years of therapy with DMRs for 2 to 5 years, then it will be worth it, but we don't know that for sure.
Okay, no, just we have to stop and to move to the last presentation, since also there is another meeting which is starting, and we would like to invite also the other people to attend. So thanks for...
Well, that was a wake-up discussion. Mr. Chairman, ladies and gentlemen, thanks for your persistence. Your persistence is going to be rewarded. I have a housekeeper announcement from Professor Martinelli. The one of you that is going to have some little brain left to make a question after my talk, a very burning question, is going to receive the prize for the first day marathon of the SOHO meeting, and the prize is going to be announced at dinner. Having said that, I must tell you that it has been a great honor for me to be here. Thank you, Giovanni, for inviting me, because it's been very nice to see the progress, for me to see the progress made in blood neoplasia, side by side on the 2 sides of the ocean. As in very clear from my slides, I am a mouse doctor. I am not a human doctor. But it's very good and very well planned that I'm here, because I'm going to give you some insight for something that is an unmet clinical need. We made a lot about things that we have done progresses and more progresses up to now. Now let's talk a little bit about what we are thinking for something that we don't know how to cure. I'm not going to talk about the new insight in biology of MN. We would be here until tomorrow. No, I'm going to give a very brief punchline. I'm going to describe some experimental data that provide the preclinical rationale for 2 new targets for this unmet clinical need, that is primary myelofibrosis. I'm going to describe to you very, very briefly the preclinical data that support the clinical trials for these 2 new targets. And I'm going to announce the 2 clinical trials that are just opened and that probably is going to be presented at ASH next year. So a glimpse on the future for primary myelofibrosis. And this is a slide here, just all of you knows what is primary myelofibrosis. It's a very bad disease. ruxolitinib does something for the symptoms. It's debatable if it does something or does not do anything for the disease progression. But it's here to show that it's a multi-trait disease. It involves cells of many, many lineages. We know that the driver mutation, it's a single gene mutation, JAK2, MPL, calreticulin, or few other genes that go around this pattern. But such a complex phenotype, a biologist will tell you, is not a single gene mutations. You have to have different abnormalities, and you have to think outside genes. When you think about primary myelofibrosis, you have to think about cells and cellular interaction. And some of these traits are here because they are clearly GATA1 dependent. You know, IMC57 red. At the difference with Beppe Saglio, I'm still an erythroid person. He left the erythroid field a long time ago, but this is bad for him and good for me. So GATA1, it's a transcription factor that controls erythroid and megakaryocytic differentiation. And if you have anemia, if you have a block in megakaryocytes production, in thrombopoiesis, GATA1 must be involved in some way. And this is a proof of concept in mice. If you make mice which express the driver mutation, JAK2, only in megakaryocytes, the stem cells are normal. The driver mutation are expressed only in megakaryocytes. The mice will develop the disease, although their stem cells are normal. So our hypothesis, and there were two different groups that have published that. So our hypothesis was that if we would identify the megakaryocytes abnormalities that drive the mutations, we may identify the druggable target. And GATA1, with Alexandro Vacnucci long time ago, and now more recently with John Crispino, we showed that if you look at the megakaryocytes of the bone marrow of the patients or of the mouse model of the disease, they do not express GATA1. They are GATA1 hypomorphic. GATA1 is not mutated, but it's not expressed in good quantities. And what we had an hypomorphic mutation, the GATA1 low mice. And sure enough, these mice that do not express enough GATA1 in megakaryocytes, with time, very, very slowly, they develop the disease. And in these mice, the disease is a disease of old age. At 12 months, they start to have only increases thrombosis or increased osteogenesis at 1 month, so that you start to have the fibrosis in the bone marrow and the increased vascularization. And then you have stem cell trafficking and you have extramedullary hematopoiesis in the liver. And so we decided to use these mice at 12 months and to treat these mice to see if we could reverse, at least in mice, the disease with some druggable target. And what are the druggable targets that we have identified? You know, megakaryocytes were the very first abnormalities identified in PMF. They were identified by Zucker Franklin. And already a lot of people, including us, have shown that the megakaryocytes of these mice express increased level of TGF-beta. And this is also what happens in our mice. And you have the histological analysis supporting that. You have also another megakaryocytic abnormalities, because the megakaryocytes are immature, P-selectin, that is the receptor that is used by the megakaryocytes to interact with the neutrophils, is expressed at a level higher than normal, both in the megakaryocytes of the mice and in the megakaryocytes of the patients. And this is our working hypothesis. These are summarized there. In some way, however you go, you decrease GATA1, the megakaryocytes become immature, they start to produce TGF-beta, they start to to express P-selectin. P-selectin attracts the neutrophils just chew up the megakaryocytes, forcing them to express, to release TGF-beta in the microenvironment, and you have fibrocytes activation, and the myelofibrosis works. So what we have tried to do, we have tried to cure the mice by blocking TGF-beta with an approach very similar to what has been described by Dr. Dalla Porta early on, and we try to block P-selectin and see what happens. This is a slide very similar to what has been done by Dalla Porta, presented by Dalla Porta. There are many drugs, very fancy, that to target the receptor. We went simple. We wanted something that we could buy off the shelves, and we did not add anything to have and to deal with a company that would say you don't publish the results. So we used this small molecule, SB431542, that I will call SB from now on. And this is the molecule. It's very, very small, so it will go in the fibrosis tissue very, very easily. And what we did, we treated the mice only for 2 months. And we treated in cycle, the boxes are the treatment. And at the end of the treatment, we chopped up the mice, and we did all the assay. And already you can see that the mice over there that are treated are slim. And they're slim because they are motile. They move in the cage. And they look healthy. Their fur is luster. And that is, it's already a sign that the mouse is better. This is an old guy. It's a 12-month-old mouse that you are looking at that. It's equivalent to a 16-year-old man. And you don't have any change in body weight, so no toxicity whatsoever. And this is the very first important slide. The megakaryocytes are normal. They start to express at GATA1 again. They have a reduced expression of GATA2. P-selectin is reduced. And the other megakaryocytic specific growth factor instead are increased. And no fibrosis in the bone marrow. The bone marrow is red. You increase the cellularity in the bone marrow. By Gomori staining, you don't see the collagen fibers, and you don't see neoangiogenesis. The spleen is shrinked. As far as we could say, the mouse is cured. So the first possible druggable element for primary myelofibrosis, the TGF-beta, and there are several interesting stuff out there that now can be treated. Dalla Porta described one of them. There is Forbius as AVID 200, and the Myeloproliferative Research Consortium has just started a clinical trial with the AVID 200, the Forbius molecule, and we will know the results next year. What did we do for P-selectin? We just deleted the gene genetically. We crossed the mouse with a P-selectin null mouse, and we analyzed the double mutants. And sure enough, do you remember that they had thrombosis? There is no more thrombosis in the mouse, although they still are piastrinopenic. And there is no fibrosis. You know, the P-selectin null GATA1 low mouse is in the middle. The P-selectin wild-type GATA1 low littermate is on the last slide. High level of fibrosis. And this is the most important slides. This is survival. And you see the survival of GATA1 low mice is, and of the GATA1 low mice that lack the P-selectin gene, they live 2 months more. That is a lot for mice that live already 22 months. But this is even more interesting. All hematopoiesis in the mice occurs in the spleen. If you take out the spleen, the mice die of severe anemia very quickly, all of them. If you give, and if you delete the P-selectin genes, you can remove the spleen and the mice do not die. A measurement that we took back the hematopoiesis in the bone marrow, so that we have reactivated hematopoiesis in bone marrow that was death in these mice when they had the P-selectin gene. So this is the therapeutic hypothesis. If we target TGF-beta, then what we do, we treat the mice, the high level of TGF-beta in the bone marrow put the normal stem cells into quiescent, in deep G0. So they block them. And by inducing fibrosis, they also reduce the niche that support the normal stem cells. And so you have hematopoietic failure on that side. If you have in the spleen instead, they produce, the increased TGF-beta induce the formation of a specific niche for the myelofibrotic clone that leads to the expansion of the clone. So if you block TGF-beta, from one side you activate the normal stem cells, and from the other side you take out the fuel of the abnormal stem cells, and this is what we think is working. What is p-selectin here? Well, p-selectin also reduces TGF-beta, and I didn't have the time to show that. So you can achieve this also deleting the p-selectin gene or inhibiting the p-selectin, and there is a very good antibody commercial under development by Novartis that works beautifully for the pain crisis in sickle cell anemia, and there is a clinical trials with this antibody and ruxolitinib that is going to start at the end of September. And now I chop to my thanks. This is my collaborator, Fabrizio Martelli, pops up always the first as my long-time collaborator, and my funding acknowledgements are the Associazione Italiana Ricerca sul Cancro and the National Cancer Institute. And thank you for your attention. So now we will see who is the winner.
We are very late, and apologize for a short discussion. If there is a burning question.
One burning question?
No, they are very tired. Okay, thanks a lot, because it was very exciting, but we found out also the occasion to represent our data, your data, and your hypothesis, which is so attractive, so special. I would like to finish this section and say thanks for the first day. It was too long, and we lose probably the control of the section. However, it was a great pleasure that you are resisting so long, so interested, yeah, they are the winner, of course. They are absolutely the winner. I would like to complete this day, remembering that it's starting a new section, a new small meeting in which there is also the opportunity to get a dinner, and so all the people who would like to attend are getting this exciting opportunity. Okay.
Okay, we want to thank also people who are following us from social network in live streaming, and we are sorry also for them for being late for so long, but we will do better tomorrow. Thank you for the attention, thank you for your presence.